Welcome to everyone on this early, little bit chilly spring morning. My name is Dave Lieuwen. I'm one of the medical directors for the Senior Health Connect program. I'm also a family doc who practices here locally at Grand Valley Medical. So as you may recall, we used to have regular clinically based webinars, but it's been a while. So going forward, we will have them on an as needed basis. We spent a lot of time in 2025 discussing heart failure, especially stage B. And since we're also going to be doing, and we've already started quite a bit of work with COPD in 2026, we thought it would make some sense to spend some time together on the topic. So as I mentioned, I'm one of the medical directors for the Senior Health Connect program, and I am compensated for this role. I have no other financial relationships to disclose. And Abbey Magolan is our other presenter, and she has no financial relationships to disclose. So we have an ambitious agenda this morning, but there should be time for questions at the end. Please use the chat function if you want to pose a question during the talk. And if we don't have time to cover each question during today's meeting, we will make a point to answer them after the webinar. So we'll start with the basics. Why are we spending time covering COPD? Who should be screened? How do we interpret in-office spirometry? And who should be screened for lung cancer? And Abby, as I mentioned, she's our Answer Health PharmD, will go over the specifics of treatment with inhaler therapy before I finish up with prevention and case studies. So there is CME credit available for today's presentation. Listed here are the learning objectives for today. So as we all know, COPD is a huge cause of morbidity and mortality, both in the US and globally. Not only is it responsible for numerous office visits and ER and hospital stays, but it is the third or fourth leading cause of death in the US, depending on the year. Further, we do not have a true picture of the overall impact, as most estimates put the number of undiagnosed cases at around 50%. I'll admit that in the past, I sent essentially all of my patients for formal PFTs, but as a result of this initiative, I'm now more comfortable identifying not only who to screen, but also administering and interpreting the in-office spirometry. If we can detect and treat these patients earlier, we can reduce COPD exacerbations and keep our patients at home. So this leads into a discussion of prevalence. We started our prevalence work with heart failure, and we defined the prevalence gap as the difference between local prevalence, as reported by Milliman, and then the actual reported prevalence in the Answer Health network. So listed here is the year-end 2025 data. As you can see, we have a real opportunity to identify more patients with a number of conditions, including COPD, get them on appropriate treatments, whether that's inhalers, vaccines, or help with smoking cessation. Okay, so this raises the question, who should we be screening? The U.S. Preventative Task Force and the Global Initiative for Chronic Obstructive Lung Disease, or GOLD, committees. So this is the U.S. and then the global committees, respectively, of experts on COPD. They both agree that population-based screening is not the best way to balance benefits with harms. Instead, they recommend screening only patients with risk factors. In this case, mostly smoking, but it also includes exposure history, which we'll cover later, and symptoms, so risk factors and symptoms. Thus, they recommend a targeted case-finding approach for screening. So to be clear, any patient with chronic respiratory symptoms and relevant risk factors warrants further testing, such as spirometry. So there's a variety of screening tools available to help us with this. At my practice, we're using the CAPTURE survey, which is listed on the right there, as part of our adult wellness visit process. Patients who are currently or who ever smoke.
Thank you so much. Thank you.
Are asked to answer 5 questions to try to determine if they actually are symptomatic or not. Oftentimes, patients have adjusted their lifestyle to accommodate for their shortness of breath and are not even really aware that they may have a problem, which is why questions like these are so helpful. So they're asked if they have a chronic cough, if the cough is regularly productive of sputum or mucus, if they have shortness of breath with even normal activities like climbing a flight of stairs, if they have regular wheezing, or if they have frequent or prolonged colds. If a patient has 2 or more of these symptoms, they are eligible for further testing, such as office-based spirometry. So a quick recap on who we are screening. Again, quite simply, it is patients with symptoms that we covered in the last lab who also have risk factors. So as I briefly noted before, risk factors are usually obvious with cigarette smoking, vaping, or significant secondhand exposure. However, it might also include patients with biomass fuel exposure, and this refers to inhalation of smoke from burning wood, animal dung, crop residues, and coal, which is, of course, a major COPD risk factor in low and middle income countries. Occupational exposures in jobs like welding, construction, mining, and farm workers accounts for an estimated 19 to 27% of COPD cases overall, and 26 to 53% among never smokers in the United States. And then lastly, if you have unusual cases in terms of early onset family history, early onset detection in younger patients, don't forget to test for alpha-1 antitrypsin deficiency in these patients. Okay, so now we know who to screen based on the case finding approach. Let's now cover how we do the testing in our offices. It's kind of a little bit of a funny aside. We chose this photo because the patient is using a spirometer that many of us are using in our own office. But obviously the patient type we'll be using this on will be quite a bit older than this young lad. So before I dive into specifics, I want to make sure that everyone is aware of resources we all have available to us as we roll this out in each of our respective clinics. So my clinic or office started this a number of weeks ago, as have many of the pod leader practices. So I really want to put forward and introduce the clinical performance team at Answer as an excellent resource. They were instrumental in the PDSA cycle, which of course is planning, doing, studying, and acting. So the PDS cycle rollout for my own practice. And they even came out to our office to both teach the MAs how to perform spirometry testing and then walk them through the whole end-to-end process, recommending ways to streamline processes and get valid results. So they developed a number of job aids, protocols for the overall process that they can actually share with your office during the training session. So the clinical support team is available, like I said, to your practice to discuss this project and to help with the rollout and the training for spirometry. And as this is going to be rolled out to more of the RBE over the next several weeks, they will be reaching out to discuss screening and training and more of the practices. Okay, so when we get a spirometry report back, there are 3 values we all need to understand. First is the forced expiratory volume per second, or the FEV1. And this is the amount of air the patient can exhale in the first second. The forced vital capacity, or FVC, is the total amount of air exhaled during the patient's entire forced expiration. And it is the ratio of these 2 values, or FEV1 over FVC, that makes the diagnosis of obstructive lung disease. If the ratio is less than 0.7, this indicates that there is an obstructive process which is limiting the amount of air expired in the first second. The patient is instructed by the MA how to do the actual forced expiration, oftentimes using nasal clips to ensure that air is only expressed from the mouth. And there need to be 3 good attempts, which the device will actually identify, in order to have a valid spirometry test. Again, these are all things that will be covered in detail during the training sessions that Answer can help facilitate. So besides the objective numbers we just covered, you will also get a flow volume loop. On the y-axis here, which is the liters per second of airflow, and then on the x-axis is the volume in liters. A normal flow volume loop is illustrated by the green line. There will be a rapid upslope, and then, in the first second, followed by a smooth remaining expiratory descent. Contrast that with the other lines, which show varying degrees of obstruction. These will have a lower initial flow and then sort of a scooped out feature to the expiratory limb, which is often prolonged. So shown another way with some actual flow loop examples, you can see the same concepts. So on the left is a normal spirometry. So you see this steep first second upslope, but then on the right you can see the much reduced initial expiration. Then the remainder of the normal slope is a nice steady descent versus this kind of scooped out, prolonged expiration in the obstructive case. The inspiratory or bottom portion of the flow loop is less important for today's discussion. So, as I alluded to earlier, the diagnosis of obstructive lung disease requires a decreased FEV1, and it's the actual FEV1 decrease which will be key in determining severity, which we'll be covering a little bit later, and also a normal or a reduced FVC. Again, the ratio of the FEV1 over FVC of less than 0.7 is what makes the diagnosis of an obstructive process. Recall that both asthma, COPD, and some other conditions are both obstructive lung diseases. So if the patient has a ratio of greater than 0.7, done, there is not an obstructive process. But if the ratio is less than 0.7, you will then have your MA administer a bronchodilator, either by MDI or nebulizer, and then repeat a spirometry. If there's reversibility or near or total normalization of the ratio, this is an asthmatic process or reversible. However, if it's not reversible, this is the diagnosis of COPD. So we've developed some useful handouts that I keep on my desk for, kind of the step-by-step interpretation of spirometry, as I know this is kind of new to many of us, or it's been a while. After doing a number of these spirometries myself recently, I feel a lot more comfortable, especially when I have my handy cheat sheet in my hand. So these will be sent out after today's meeting for you to use. So now we are left with a patient who is symptomatic, who had an initial spirometry with an FEV1 to FVC ratio of less than 0.7, and then a follow-up spirometry after bronchodilator treatment that did not show reversibility. Next, we have to determine how severe the patient's obstruction actually is. For this, the GOLD criteria, which were just re-released this year, these are key, and you need to look at the FEV1 value and the patient's symptom severity and the number of exacerbations. And it just kind of makes intuitive sense that the lower the FEV1 value and the more symptomatic in terms of effect on ADLs and exacerbations, well, the worse the patient's obstructive lung disease actually is. So again, this will be key to our later discussion about the actual treatments available for these patients. Okay, so we're going to shift gears here to remind everyone that as we're screening for COPD, we can't forget that many of these same patients are also at increased risk for lung cancer, heart disease, and etc. Having COPD independently increases the risk for lung cancer, and many of these same patients also qualify for low-dose CT screening. I think, as we all know, prior attempts to screen for lung cancer and captured in its early, more treatable stages were unsuccessful, using modalities like sputum collection, chest x-rays, etc. I remember seeing the National Lung Screening Trial, which was published in the New England Journal in 2011, and then, by the way, was subsequently corroborated in 2020 by the Nelson Trial. This was the trial which showed the mortality benefit from using screening low-dose CTs in high-risk smokers. The trial showed a 20% relative reduction in lung cancer mortality and a 6.7 reduction in all-cause mortality in the low-dose CT group as compared to those screened with annual chest x-rays, all by virtue of earlier detection. So talking with patients about this can also be a nice springboard to discussion about smoking cessation as well. But unfortunately, approximately 70 to 75% of lung cancers are still diagnosed beyond stage 1. However, the exact proportion has been shifting over time due to increased screening uptake. There is a lot of opportunity here, though, as screening uptake remains low nationally. 2020, it was only approximately 18% of eligible individuals received screening. So I know there's a lot of things that we have to cover in an office visit, especially if it's an adult wellness visit or physical exam. So because of this, I just kind of want to remind everyone about who should be receiving low-dose CT screening. So per the U.S. Preventative Task Force, all patients should get annual low-dose CT screening if they are three things: 50 to 80 years old, plus a smoking history of at least 20 pack years, and if they are current smokers or quit less than 15 years ago. So it makes sense to stop screening if the patients quit longer than 15 years ago or are in poor health. Kind of an important caveat for payment is that Medicare does cover low-dose CT screenings as a preventative service, meaning no cost sharing, for eligible Medicare beneficiaries, but only those between 50 and 77. I'm not sure why it's not 80. You must document the basics of shared decision-making in your note as well. And in the appendix, you will see kind of the specific information required. So it bears noting that in the process of low-dose CT screening, there are several conditions that are commonly found, each which is in the same HCC category as COPD. You may find a number of these as recommendations on your MIP forms. So a 2025 systemic review and meta-analysis found that among lung cancer screening participants, 45% had emphysematous changes noted on CT. Remember, emphysema does not require PFTs for the diagnosis. It can be diagnosed off of radiographic findings. And the same statement can be found for bronchiectasis. If bronchiectasis is noted on a CT, that can be diagnosed off of the radiographic findings. I know something that I'm not always so good about remembering, but chronic bronchitis. Well, this, of course, is a clinical diagnosis, which is diagnosed in patients who have had a productive cough on most days for at least 3 months of the year for 2 consecutive years, after excluding other chronic cough causes. And then, of course, COPD does require the PFTs or spirometries, which is what we've been talking about. So lastly, I think it just makes sense to consider screening patients who have had these sort of CT findings with the capture survey, because again, if they're symptomatic, they should be considered for spirometry, as we discussed earlier, because they might benefit from medication treatment. So we've included here the relevant ICD-10 codes for the various obstructive lung diseases that we've been discussing, as well as the codes for tobacco use and tobacco cessation counseling codes. You can also see the code for the low-dose CT screening and the actual CPT code for the CT. Okay, so before moving into treatment, let's review some of the key takeaways. So first, COPD is common, it's serious, and it's often underdiagnosed. We know from local data that there's a prevalence gap between the expected and the diagnosed COPD prevalence. As with the echo screening that we've started, we want to reduce that gap to accurately show the disease burden in our population. In-office spirometry is essential for confirming COPD in appropriately screened patients. Again, those with risk factors and symptoms. Accurate interpretation relies on interpreting 3 key values: the FEV1, FVC, and then the ratio of those two. And then low-dose lung cancer screening is a critical preventative tool for high-risk patients. So I'd like to introduce our next speaker, Abbey Magolan. She's, as I mentioned, a PharmD who works with Answer Health Practices to optimize medication management. Today, she will be sharing evidence-based treatment options for COPD.
Thank you, Dr. Lieuwen. GOLD has released their new 2026 guidelines for COPD, which came with some changes for how we treat. First, we will talk about the initial treatment. This is from the GOLD guidelines, but recreated to be a little easier to read, as it is flipped if you were to look in there. You will see on the left side, it talks about how many exacerbations a patient has had in the previous year. This is where the guidelines have changed for initial treatment. If the patient has had 0 exacerbations, they will fall into that top row of either group A or group B. But if the patient has had even 1 moderate to severe exacerbation, they will fall into that bottom row and automatically fall into group E. Looking at the columns at the top, you will see scores for MMRC and CAT. There are several ways to quantify symptoms for patients with COPD. Here we talk about some of the simpler ones that are also included in the guidelines. MMRC, or the Modified Medical Research Council Dyspnea Questionnaire, which you will see on the right, is one of the 2 symptom questionnaires we need patients to fill out when they are diagnosed with COPD. The other is the CAT, or COPD Assessment Test. This, again, is a questionnaire for your patient to fill out. Depending on the patient's score for the MMRC and CAT, they will either be grouped into Group A or B for no exacerbations, or again, Group E for at least 1 moderate to severe exacerbation, regardless of those MMRC or CAT scores. I do have some practices that have these questionnaires printed and laminated for patient to use a dry erase marker on. This way, the questionnaires can be reused. Now, I'd like to dive a little deeper into what each of these groups mean. Starting with Group A, a bronchodilator. Just as a refresher, bronchodilators are going to open up or dilate those airways. We have either short-acting or long-acting bronchodilators, and each of these can be further broken down into beta agonist or muscarinic antagonist. Group A is only needing a single medication inhaler for initial treatment. Long-acting medications are preferred over short-acting, except in patients with only occasional dyspnea. Group B patients should be started on a LABA plus a LAMA. Now, for these medications, a single inhaler is preferred over multiple inhalers due to both adherence and cost. Group E patients would also be indicated to have a LABA plus a LAMA, but for these patients, we should also be adding an inhaled corticosteroid or ICS if the blood eosinophil level is 300 or more. All patients with COPD need to have their blood eosinophil levels checked. This is completed with a CBC with diff lab test. I would also like to note that we should be looking at non-pharmacological treatments at diagnosis as well. This includes smoking cessation, pulmonary rehabilitation for groups B and E, physical activity, and vaccinations. Exacerbations, as defined in the GOLD guidelines, are acute events classified as mild, moderate, or severe, with symptoms worsening over a few days but up to 14 days. They are categorized by increased dyspnea and/or cough and sputum. Exacerbations may be accompanied by tachypnea or tachycardia. They are often associated with increased local and systemic inflammation caused by airway infection, pollution, or other insults to the lungs, although the cause is usually unknown. Exacerbations may be managed outpatient or inpatient, and recovery time can vary but may last up to 6 weeks. These exacerbations should be treated as soon as possible to prevent complications in subsequent events. Initial bronchodilators for moderate or severe exacerbations are SABAs with or without SAMAs. We can use systemic corticosteroids for up to 5 days, but longer use of corticosteroids is associated with an increased risk of pneumonia and mortality. Antibiotics are an option when the patient has increased purulence of sputum with at least one of these other symptoms: increase in dyspnea, fever, or increase in sputum volume, or if the patient has had a positive sputum culture during a prior exacerbation, or are requiring mechanical ventilation. The choice of antibiotics should be based on local bacterial resistance patterns. Next, we will move on to follow-up treatment. This is from the GOLD guidelines with some modifications. First, we will follow up for exacerbations. There were no changes to this with the newest guideline update, but I would like to go through it as a refresher. When a patient follows up with you after a moderate to severe exacerbation, we need to look at the blood eosinophil levels, hopefully during that exacerbation, as this will help guide our treatment decisions. You will see that in this algorithm, the decisions will be based off of the patient's blood eosinophil levels, which again is checked with a CBC with diff lab test. I would also like to add that I have talked to pulmonologists who have noted that patients with COPD are coming to them too late. It was suggested that in primary care, we refer to pulmonology if a patient has had more than one exacerbation or at least one hospitalization due to their COPD. The pulmonologist will then be able to add on some other specialized medications, which may include biologics. We should be following up with these patients at least twice after an exacerbation. The first follow-up is 1 to 4 weeks after that exacerbation or discharge. This is when we will evaluate their ability to cope with their usual environment, review understanding of the treatment regimen, reassess inhaler techniques, reassess need for long-term oxygen, document the capacity to do physical activity and consider patient eligibility to enroll in pulmonary rehab, document symptoms with MMRC and CAT, and determine status of comorbidities. We should then have another follow-up in 12 to 16 weeks after that exacerbation. Here we will complete all of the above plus measure spirometry. At these follow-up visits, please also discuss non-pharmacological treatment. Some additions to the follow-up visits include self-management education, assessment of behavioral risk factors and environmental exposures, and making sure the patient is getting adequate sleep and eating a healthy diet. Now we have follow-up for dyspnea. If the patient has persistent dyspnea, we need to look at their current regimen. If they are currently on a single agent of a LABA or a LAMA, then we need to look at starting them on a LABA plus a LAMA. As I discussed earlier, we want to try for that single inhaler with combined ingredients if possible. If they have that combined inhaler, but we are still experiencing dyspnea, we need to move to that last box, which has a few options. 1, we need to reevaluate the type of inhaler the patient has. Maybe the patient has a dry powder inhaler, but they aren't able to breathe deep enough to get that medication into the lungs. Maybe they need a soft mist or metered dose inhaler with a spacer instead. 2, we can look at non-pharmacological options for the patient. Note that the self-management education details are different in dyspnea versus exacerbation follow-up. 3, which is the part added to the guidelines, is to consider adding ensifentrine, which is a nebulizing solution. And 4, the last part, would be to investigate other possible causes of the patient's dyspnea and treat those. Moving into the actual medications, we are going to start with the bronchodilator single agents. We have long-acting beta agonist, or LABA, which includes Ceravent Discus and Striverdi Respimat. Long-acting muscarinic antagonists, or LAMA, include Incruse Ellipta, Spiriva Respimat or Handihaler, and Tudorza Pressair. Short-acting beta agonists, or SABA, include Ventolin and Xopenex, and short-acting muscarinic antagonists include Atrovent. Remember here that long-acting agents are going to be preferred except in patients with only occasional dyspnea. Going into some of the combinations we will use in COPD, we have a LABA plus a LAMA agents, which include Anora Ellipta, Bevespi Aerosphere, Ducalair Pressair, and Stilota Respimat. These are going to be our main agents for COPD. If you remember in the treatment algorithms, this is our most common class shown. Our last grouping is our LABA plus LAMA plus ICS agents, which include Breztri Aerosphere and Trelegy Ellipta. But you may be wondering, when do we add an ICS to the patient's regimen? GOLD guidelines strongly favor use when the patient has had a history of at least one hospitalization for exacerbations of COPD, 2 or more moderate exacerbations for COPD per year, both of these despite appropriate long-acting bronchodilator maintenance therapy, blood eosinophils of 300 or more, or history of or concomitant asthma. The guidelines favor use for 1 moderate exacerbation of COPD per year, despite appropriate long-acting bronchodilator maintenance therapy, or if the blood eosinophils are 100 to less than 300. On the other hand, we want to make sure that we are avoiding use of inhaled corticosteroids in patients with repeated pneumonia events, those with blood eosinophil levels less than 100, and those with a history of mycobacterial infection. If there is an indication for an ICS, the combination LABA plus LAMA plus ICS has been shown to be superior to LABA plus ICS and is the preferred choice. We talked about when to add or not add ICS to a treatment regimen, but we also need to make sure that we are re-evaluating ICS therapy if needed. There are risks that come with inhaled corticosteroids, and we may need to do a de-escalation of therapy. According to the European Respiratory Society, or ERS, regular treatment with ICS increases the risk of pneumonia, especially in those with severe disease. Other risks include mycobacterial disease, increased incidence and poor control of diabetes, osteoporosis and bone fractures, oral candidiasis, and dysphonia. The European Respiratory Society released guidelines in 2020 about when to withdraw or stop ICS in patients with COPD. After this presentation, you may be re-evaluating a lot of your patients and their current treatment. There is excessive and inadequate use of ICS in patients with mild or moderate COPD who are at low risk of exacerbations. If patients are on an ICS either alone or in combination with another medication, but their blood eosinophil levels are less than 300, we need to look at de-escalating the ICS component. Efficacy of ICS in the prevention of exacerbations is higher in patients with high concentrations of blood eosinophils, but is very limited in patients with blood eosinophils below 100. To evaluate patients, we need to look at their blood eosinophil levels in steady state and review exacerbation history in the previous year. Please note that systemic corticosteroids can and will suppress blood eosinophil counts, and to not use values taken during or after a recent course of oral corticosteroids. The ERS recommends that in patients with COPD without a history of frequent exacerbations, consider ICS withdrawal. In patients with COPD and a history of frequent exacerbations but less than 300, there is no recommendation that can be formulated due to a lack of evidence. However, do not withdraw ICS in patients who have blood eosinophils of 300 or more, with or without a history of frequent exacerbations. They continue to say that if ICS are withdrawn, patients should be treated with 1 or 2 long-acting bronchodilators. From their literature review, they have found that ICS can be abruptly withdrawn in the majority of cases. After stopping the ICS component, please be sure to continue monitoring for exacerbation frequency, symptoms, and lung function. Many of you are probably thinking this is great and all, but how do we decide which inhaler we're using from all these options? On the right, you will see most of the many different types of inhaler devices that are currently on the market. This includes Twishaler, metered dose inhaler, discus, press air, Flexhaler, Respimat, Ellipta, and Inhub. These all have different directions on how to use them, and they may not work well for all patients. There are some things we have to consider with these different devices. 1, inspiratory flow. Is the patient able to breathe in deep enough to get that medication into the lungs? 2, cognitive function. Per GOLD, there is an estimated average prevalence of 32% cognitive impairment in patients with COPD, but extensive testing suggests that up to 56% of patients with COPD have cognitive impairment. 3, manual dexterity. And 4, insurance coverage. This, unfortunately, will probably be the deciding factor for a lot of these medications. Please know that for commercial patients, most of these inhalers do have copay assistance cards online through the manufacturer. For those with Medicare or are uninsured, they may qualify for an inhaler through the manufacturer's patient assistance program. When we start a patient on an inhaler and at each follow-up, we want to make sure that we go through how to use the inhaler. First by showing them, then using the teach-back method. There are a lot of patients that use these inhalers incorrectly and are not getting the medication into their lungs because of it. Inhaler technique is very important here. There are videos online through the American Lung Association that can help with this. Inhalers come with directions in the box as well if a patient were to forget. If you do choose a metered dose inhaler, please send in a separate prescription for a valved holding chamber or spacer. There are many different manufacturers of these, but if you send in for a generic one, the pharmacy will be able to fill with what is covered by the insurance. All metered dose inhalers should be used with a spacer. Some resources you may be able to utilize include the manufacturer's website, the patient's insurance's online searchable formulary, the American Lung Association website and YouTube page, as I had mentioned before, and the Inhale CQI website. You may or may not be aware of the Inhale program, but this is a collaborative quality initiative that I am the PO clinical champion of through Answer Health. We do have some offices that are a part of this program, but please know that their website is open to anyone and they have great resources. I've also compiled a lot of resources for inhalers as well as COPD treatment that I'm always happy to share if anyone would like them. Thank you all, and now back to Dr. Lieuwen.
Wow, thanks, Abby. That was great. So building on what Abby taught us here, for the patients with severe obstructive symptoms, we should also consider advanced therapies, such as pulmonary rehab and oxygen therapy. For patients at this point, we will certainly have our pulmonary colleagues on board. So appropriate candidates for pulmonary rehab include adults with chronic respiratory diseases who remain symptomatic despite optimal medical therapy. Pulmonary rehab is a multi-week process of exercise training, education, and behavioral change that has been shown to reduce shortness of breath and hospitalizations and to increase exercise capacity and quality of life. So for our patients with severe chronic hypoxia, we also need to consider long-term oxygen therapy. So based on several trials actually dating back to the 1980s, which are noted in the bottom here, oxygen therapy reduces mortality by approximately 50% in COPD patients with severe chronic hypoxia, and that's defined as a PaO2 of less than 55 millimeters of mercury or less than 60 in patients with cor pulmonale or polycythemia. However, just as interestingly, chronic oxygen provides no mortality or morbidity benefit in patients with moderate hypoxia or isolated nocturnal desaturations. Okay, so we've covered a lot today, and I want to make sure that we also discuss prevention of COPD. And there's, of course, two primary things we have at our disposal. First is helping with smoking cessation, and then next would be use of appropriate vaccinations. So I think we all know that smoking remains the leading cause of preventable death in the United States. It's responsible for more than 480,000 annual deaths. That includes death from secondhand exposure. This represents approximately 1 in 5 deaths in the US each year. So I thought I'd also just list some of the key health improvements over time when patients quit smoking. So as quickly as 20 minutes after that last cigarette, one's heart rate and blood pressure begins to normalize. And then again, over several months of not smoking, lung functions improve, symptomatology objectively improves as well. Cardiovascular risk drops in half after a year's cessation, and then goes down to that of the general population after 15 years of not smoking. And lung cancer is halved after 10 years of not smoking. So smoking cessation is something we can do to help really anyone at any age to reduce both mortality and morbidity, and should be key in our efforts as primary care doctors. So we've got several drugs and combination therapies available to patients to aid in this. So in 2006, varenicline, or Chantix, was released with its unique mechanism of action. Prior to this, we only had bupropion or Wellbutrin, and then the various nicotine replacement therapies. So varenicline is the most effective medication option when used in isolation. There are improved outcomes, though, when you combine therapies, especially the varenicline and the nicotine replacement therapies. Additionally, never forget that behavioral counseling, such as the 1-800-QUIT-NOW number, physician advice, etc., especially when added to the pharmacotherapies, is the most effective of all the modalities when you look at the 6-month quit rates. So included in this slide is some helpful information as to how to use and titrate these medications. So what else can we do? Given the underlying pulmonary disease with COPD, these patients are, of course, at increased risk for respiratory infections of all types. Also, if an infection happens, these patients are at increased risk for bad outcomes, whether it's going to the hospital, respiratory failure, or even death. So preventing respiratory infections from happening in the first place thus becomes key in the prevention aspect of COPD care. For this, it's absolutely vital we get our patients on all the relevant immunizations. So what are they? So in addition to the routine vaccine schedule, the most important vaccines for our COPD patients are, so first, annual influenza shots, next, giving a one-time Prevnar 20 or Prevnar 21 vaccine on or after the age of 50. Remember that pneumonia vaccines can and should be started before 50 for those patients with COPD, diabetes, smokers, etc. Next, COVID shots as available. For patients at or above 65 years of age who are moderately or severely immunocompromised, the ACIP recommends a second dose of COVID vaccines, and they did that in both the 2024 and 2025 cold and flu season. And that would, of course, be given 2 to 6 months after the initial dose. The RSV vaccine, which is at present a one-time shot. Tdap, of course, we need to protect against pertussis, specifically if they haven't received this the Tdap booster before, and then the Shingrix or the shingles vaccine. So some key takeaways. Long-acting medications are preferred unless the patient has only occasional dyspnea. Inhalers with multiple medications in one device are preferred due to adherence and cost. Patients with severe respiratory disease, despite maximal pharmacologic treatment, remember to consider pulmonary rehab and oxygen therapy. Continue to offer smoking cessation advice and treatment for ongoing smokers. And then appropriate vaccines remain key to the prevention of respiratory infections, especially for those with lung disease. Okay, so now we're going to try to pull these concepts together. So this is sort of our attempt at audience participation, so feel free to chime in. All right, so you are seeing a 55-year-old female patient with a 30-pack year smoking history. She notes a chronic daily cough and shortness of breath with minimal exertion. So what would you do next? Dr. Millett?
Hey, Dave, great presentation. Appreciate everything. I think in this case, probably confirm that they have some sort of COPD, or at least test them with spirometry, and then maybe evaluate their symptoms, kind of see what they're experiencing, and maybe even go over some treatment options if they have the diagnosis. Certainly with their history, think about low-dose CT scan and smoking cessation.
Fantastic. So, as John said, start with spirometry. Remember that the FEV1 to FVC ratio of less than 0.7 is required to confirm the obstructive lung disease. And then again, if they have that, then you would do also a post-bronchodilator spirometry. And it's that lack of reversibility that makes the COPD diagnosis. Next, you're going to want to assess the severity based on the GOLD criteria using the FEV1. CAT and MMRC assessments are also super important as per Abby's talk, because those help to guide which inhalers are most appropriate for the patient. And then, like John said, I think just never miss an opportunity to counsel patients on smoking cessation and offer, medication and behavioral modification to help with this. Of course, give all the vaccines we just discussed and order the low-dose CT as appropriate. Okay, so next we have a 68-year-old patient with worsening shortness of breath, productive chronic daily cough, easily fatigued with basic ADLs, and actively wheezing. So spirometry shows a ratio FEV1 to FVC of 0.6, with no reversibility after bronchodilator treatment. FEV1 is 58%, and then that CBC with differential shows 350 eosinophils. The CAT and MMRC scores are both elevated. So what is our diagnosis? And what would the gold group be for this person? Troy?
I think the diagnosis would be probably moderate COPD, and the gold criteria would be 2, based on the 58%.
Great. So gold criteria, the second group, based on the 58% as well as the symptomatology. How about treatment on this patient? Troy, you want to take it?
Sure. This would be based on the criteria we just reviewed, would be a triple therapy. So it'd be the combination of the LABA/LAMA along with an ICS, given the patient's clinical presentation.
Excellent. So again, this is the person. Abby was pretty clear. We should just be doing LABA and LAMA unless there are, the two things. One would be the increased eosinophil count, and this person, they're above the 300, and or if they have had multiple moderate or greater exacerbations. So yeah, triple therapy for this patient. And then again, all the relevant vaccines and help with smoking cessation, and even considering pulmonary rehab and assessing for chronic oxygen. Thank you, Troy. Okay, well, this kind of concludes where we're at. Thank you so much for attending. Now will be a chance if there are any questions that you might have. I also want to use this as a chance to remind you once more that Answers clinical support team will be reaching out, or you can reach out to them. There's their contact information to help roll out the spirometry screening program. On the next slide, there is the QR code that you can scan to claim CME credit for today's webinar. So I'll actually open up to that, but please, if there are questions, let us know. Ready to field them.
I also dropped the link to the survey in the chat for anyone who wants to click on it there.
Just while I'm waiting on questions, there is an appendix with a couple of useful things as well. So the slide deck, along with the handouts that, so Abby created a really nice handout, and then the handout that I referred to in my part, which is the actual flow chart for how you get to the screening, and then how do you actually interpret the spirometry. Those will all be sent out as well. And then over time, hopefully those will be delivered to you, because those are going to be in laminated form as well. Again, I just keep it right next to my desk. Matt, can you let me know if there's anything in the chat, because I can't see that.
Yep, I'll let you know if anything comes in.
I'm just scanning it myself here.
Dr. Kanibi, one of the resources that will be sent out that I helped create is one with some coverage of formulary details, especially for Blue Cross Medicare and Priority Health Medicare, as that's what we kind of see the most in our population. So hopefully that'll help. If not, please reach out to me, because I am the pharmacist at your practice. So hoping to help with any of those questions as well.
Yeah, Abby's just such a really nice resource for these sorts of things and others. So put her to work.
Hey, Dave, there's a question from Kevin Anderson that asks, do you do albuterol pre and post for all screening PFTs?
Not pre. But remember, if the so you just go off of the ratios, so that the machine will identify on the initial spirometry if you have, you have to have at least 3 sort of valid reproducible efforts. And then if the ratio is above 0.7, you're kind of done. But if it's below that, yes, then you will give the bronchodilator. And in my office, we give it through we give it through nebulizer, but we're also kind of working to see if we could do it through the MDI, because I think that'd be a little bit faster. And then you wait 10 minutes, and then you repeat to get the post. And initially when I started this might be a good time to talk about this. I was concerned about this really slowing me down. And so what I've done with my nurse is essentially, when I come out of the room and my nurse is Brooke, I say, hey, Brooke, I need spirometry in, room 23. She'll come in and do that. But before she does it, she actually rooms my next patient. So I'm seeing that patient, because it takes a while to do the spirometry. If the ratio is below 0.7, we have a standing order that she can then just start with the nebulizer, because again, that's the part that takes quite a bit of time. If I'm done with the other patient at that time, then after she gives the nebulizer, she'll then room my next patient. So then I'll see them. And by that point, typically the post will be done, and then I'll just go back in and finish up with the initial patient, go over the spirometry, and then discuss what the treatment options are going to be. Of course, I take my little handy one-pager with me so I can remember how to interpret the spirometry. So hopefully that's clear. I think I'll just keep talking a little here. I think the low-dose CT screening, like I shared, I'm not great at it, but as a result of this, I've certainly been much more cognizant of it. I mean, you have to, really kind of have the patient give you an accurate reflection of how much they've smoked, because the total cumulative pack year exposure is key to this. Of course, if they've quit more than 15 years, then they're sort of ineligible, or if they're outside of the age range of 50 to 80, they're not eligible. But there's a lot of people that fall into that group. And again, that was a fairly compelling trial, and then corroborative trial where we can identify stuff earlier and save patients' lives. So I'm really trying to do a better job of making sure that we're identifying these people. There may be some help in the future with use of AI to identify folks that are candidates, but I think that's a little bit in the future. And then remember, emphysema, bronchiectasis, those are radiologic findings. So use those if that is found in there, and then of course treat appropriately. Those patients probably should be getting spirometry if they're symptomatic, as we shared earlier. So again, those are important findings as well from the low-dose CT. Abby, do you have any other words of wisdom? Otherwise, I think we can close.
Just look out for the resources that we're going to send to you guys after this. I put a lot of time into the extended handout because that's the one that has the coverage details. It has links for the patient assistance programs, things like that. There's a bunch of resources on there as well. So the other one is just kind of like a little pocket guide. So just take a look at those when you guys get those.
Well, hey, thank you all for getting up early and joining us. Appreciate it. Our contact information is there if you have additional questions. And again, please make use of the clinical team to get this propped up, because there is a fair amount of work that needs to be done for that. And they were just so helpful to my office and to our medical assistants, so that we could make sure that A, we were doing it, and B, we were doing it in a reproducible fashion. So thank you everyone for joining.